Good evening, everybody. I'm Gary Lewis. I'm a professor of medicine at the University of Toronto. I'm an endocrinologist and absolutely delighted to be chairing this first session with Dr. Alice Chang. And we've just had 15 minutes of chatting to each other, one of my favorite people and a fantastic educator. So I'm absolutely delighted to share this with Alice. I hope you all enjoyed the first day of this really wonderful meeting. I certainly enjoyed it very, very much. We are going to introduce our first speakers. Alice, over to you. You'll introduce the first. I'll introduce the second, etc.
Thank you. Thank you very much, Dr. Lewis. Pleasure to share the stage with you as well. And we're going to be hearing from three fantastic speakers. And the first one we're going to hear from is so famous in the diabetes world that he really goes by just one name. So you either just know him as Dan, and I think if we just say Dan, people know who we're talking about. So we're going to hear from Professor Dan Drucker, who is a professor of medicine at the University of Toronto and Canada Research Chair in Regulatory Peptides and the Banting and Best Diabetes Center, Novo Nordisk Chair in Incretin Biology. And needless to say, Professor Drucker has won numerous awards that I don't have time to go into, but probably the other important thing to know about him is he is a fantastic golfer, and we are going to be hearing from Dan.
Thanks, Alice. And as we said, the talks will roll one after the other. So I'm going to introduce the second speaker, Dr. Mansoor Hussain. And Mansoor is a professor of medicine in the Division of Cardiology at the University of Toronto. He's also executive director of the Ted Rogers Center for Heart Research. And he has made seminal contributions in our understanding of the molecular basis of various aspects of cardiovascular disease.
And then the final speaker is going to be Dr. Sean Wharton, who is a good friend and colleague. He holds a doctorate in pharmacy as well as medicine and is the medical director of the Wharton Medical Clinic, which is a community-based internal medicine, weight management, and diabetes clinic that has really grown tremendously. He's an adjunct professor at the McMaster University in Hamilton and the York University in Toronto. And he has been part of the Diabetes Canada Clinical Practice Guidelines on Weight Management for several iterations, and most recently co-chaired the 2018 Canadian Obesity Guidelines. So we've got a fantastic lineup, and without further ado, let's kick it off with the videos.
My name is Daniel Drucker, and I'm delighted to discuss some of the cardiovascular mechanisms of action of GLP-1 and related members in the class. As you can see, we are also very busy this year at the University of Toronto hosting a scientific celebration for the discovery of insulin 100 years ago. This virtual event is free online, and I hope you'll take the time to join us and take a look at some of the scientific content we have on offer. Now, here are my disclosures. These are some of the companies that I interact with in the field of GLP-1 and incretin-based therapies. The reason we have a great interest in the biology of GLP-1 preclinically in the cardiovascular system is quite simple. It's summarized by this analysis here for the major cardiovascular outcome trials. And as reviewed in more detail by Professor Mansoor Hussain in this lecture series, for the most part, the more powerful, long-acting GLP-1 receptor agonists reduce heart attacks and strokes and cardiovascular death. And this is, I think, a really amazing result for the field and begs the question, how does this happen? So we can take a look at the approach to understanding the mechanisms using several different approaches. What our lab likes to do is basically start with a simple question and say, where are the receptors? In fact, the GLP-1 receptor is fairly widely distributed within the body, but surprisingly, it's expressed on very few cell types within most organs. And so it's not always easy to draw a line between where the GLP-1 receptor is and what the actions are that are so exciting and of biological and clinical interest. We know, for example, that the heart has GLP-1 receptors, and as well, blood vessels have GLP-1 receptors, but most cells in the heart don't express the GLP-1 receptor, and most blood vessels themselves, as well as most cells within blood vessels, do not express the GLP-1 receptor. So it's not a simple matter of automatically assigning direct actions of GLP-1 on a particular organ just because there may be low level of receptor expression within that organ or cell type. Now, a controversy in the field is whether or not there's a second GLP-1 receptor, and at least in our hands using mouse genetics, we find that all of the major metabolic actions, such as glucose control, lipid lowering, or, for example, body weight control, these are all mediated through the known GLP-1 receptor and lost when we disrupt the receptor. Here's one example: angiotensin II induced hypertension in a mouse. Blood pressure is reduced with liraglutide, and if one repeats the experiment in GLP-1 receptor knockout mice, we no longer see the blood pressure reduction. In fact, we don't see a change in heart rate or cardiac protection either. So at least in our hands, the known canonical GLP-1 receptor is really the important target to focus on. Now, here's an example from Sebastian Stevens' lab of honing in on the role of blood vessels and very specifically endothelial cells. In this mouse model with angiotensin II infusion, we see endothelial dysfunction, a failure to relax blood vessels properly, and increased blood vessel inflammation and reactive oxygen species. We completely lose all of these actions in response to liraglutide when we study the GLP-1 receptor knockout mice, and we also lose the majority of the benefits of liraglutide when we study an endothelial selective GLP-1 receptor knockout mouse. In contrast, if we knock out the GLP-1 receptor from macrophages or myeloid cells, for example, we don't lose the beneficial actions of liraglutide. So experimentally, it's possible to localize some of the benefits of GLP-1 receptor agonists by looking at endothelial cells as a target. Now, what about the human heart? In the mouse and rat, we and others have shown that this is predominantly an atrial receptor. But in the human heart, when Laurie Badger looked at dozens and dozens of sections from the 4 chambers of the human heart, to our surprise, we see receptor expression in all 4 chambers of the human heart. But challenging us is the actual localization of the protein. In fact, either by in situ hybridization or by immunocytochemistry, we cannot convincingly localize the exact cell types that express the GLP-1 receptor in all of these chambers, with the exception of sinoatrial nodal cells, which are now, I think, well-accepted sites of GLP-1R expression. So this is still a bit of a mystery to us. Here's another striking observation that we see both in animals or, as shown here, in humans, namely that when one administers GLP-1 to humans after a meal, in this case liraglutide, we see a profound reduction in circulating levels of ApoB48-rich chylomicrons. Now, if one looks at enterocytes, which are the sites of fatty acid uptake and chylomicron synthesis in the gut, we don't see the GLP-1 receptor in enterocytes. Well, maybe it's indirect through the nervous system, one might say. In fact, we've knocked out the GLP-1 receptor from either the hypothalamic and brainstem and enteric neural sites, as well as from the autonomic neural sites, including the nodose ganglia, and we still don't lose the hypolipidemic actions of GLP-1. So again, how this happens still requires further mechanistic interrogation. We know that GLP-1 reduces inflammation, and this is quite a popular theory for how GLP-1 might reduce atherosclerosis. We can see reduction in circulating biomarkers of inflammation, and probably at least some of this is weight loss independent. Now, where's the GLP-1 receptor in the immune system that might explain these observations? In fact, the cell type that has the highest level of GLP-1 receptor expression in the immune system is the gut intestinal lymphocyte, which probably makes sense for intestinal incretin biology because we have a lot of microbes and microbial metabolites that are pro-inflammatory. But that does not explain how GLP-1 reduces inflammation, and it does in distal organs which are not populated by immune cell positive cells that express the GLP-1 receptor. So drawing a line between the immune system and the GLP-1 receptor and reduction of inflammation is not always easy to do. So there's a lot of interest in making GLP-1 better using perhaps coagonists or triagonists with additional added peptide moieties. And among the favorites currently is adding GIP because of this molecule, tirzepatide, developed by Eli Lilly, which is currently in phase 3 clinical trials and produces remarkable reduction of glucose and body weight. So how does this molecule work? I really don't fully understand. I think there are many theories that we've summarized here, and it could be a contribution of some of these interactions between the GLP-1 and the GIP receptor. And there's a lot of interest in figuring this out so we can make better coagonists in the future. There's also a cardiovascular outcome trial underway to ask the question, will tirzepatide be as good in this case as dulaglutide, the active comparator, a very unique trial design having two incretin-based therapies head-to-head in a single trial. This will probably take another 1.5 to 2 years to read out, depending on the accrual rate. So what we've seen over the last decade or so is an established validity for using GLP-1 to treat diabetes, to treat obesity, and exploration of whether this class of agents might be useful to treat NASH, as well as perhaps even Alzheimer's disease. Many of these diseases share enhanced inflammation as a common soil contributing to the pathophysiology. And I think we'll see a lot more work in the future trying to tease out the exact mechanisms through which GLP-1 works to produce benefits that we see in the clinic. These are the people in my lab that have carried out the studies, and I'd like to thank you very much for your attention.
Hello. I want to begin by thanking Professors Yellen and Drucker for including me in this program. Over the next 8 minutes or so, I've been asked to speak about the clinical benefit of modern therapy for type 2 diabetes with a specific focus on GLP-1 analogs. Here are my disclosures. So as you can tell from this plot on the left-hand side of the slide, the incidence of complications, cardiovascular complications of diabetes, have been pretty stable in the general population. In the adult population in the US from 1990 to 2010 went from 178 million to 226 million. There was a bit of a fall in the incidence of acute myocardial infarction, but the rate of stroke, amputation, end-stage renal disease stayed pretty stable. Now, this might appear somewhat discouraging, but in actual fact, an examination more closely of individuals with diabetes shows considerable improvement. There's been significant falls in both the risk of acute myocardial infarction and stroke, and smaller falls in amputation and end-stage renal disease. The troubling number, however, is at the top. where there were 6.5 million diabetics in 1990, and now in 2010, there are 3 times as many. And of course, if you look at that incidence rate per 10,000, it's a much larger number than the incidence rate in the general population. So we know that there is continued high incidence and prevalence of cardiovascular complications in people with diabetes. Now, as Ray and colleagues showed in their meta-analysis of the intensive glucose lowering trials, if you try to treat various cardiovascular risk factors in patients with type 2 diabetes, you get differential benefit. Lowering blood pressure and lowering cholesterol seems to have a much more potent effect than lowering blood sugar. In other words, the treatment of diabetes focused on glycemia is not particularly effective at reducing cardiovascular events. But this study was from 2009 and really used traditional glucose lowering treatments. At that time, we had, of course, metformin, sulfonylureas, the PPAR gamma agonists, just started using DPP-4 inhibitors, and insulin. The world completely changed, of course, when we began to get new classes such as the Sglt2 inhibitors and the GLP-1 receptor agonists. In this review by Nock, looking at some of the effects of both short-acting and long-acting GLP-1 receptors, you'll see reductions in A1C, reductions in body weight, reductions in blood pressure, reductions in various lipid parameters with the small cost of an increase in heart rate. Overall, the data are summarized here. Most of these data are from individuals with type 2 diabetes without cardiovascular disease. These were in the glycemic efficacy trials, but we see significant reductions in A1C and weight, small reductions in blood pressure, and small reductions in lipids. At the same time, the Sglt2 inhibitors also have many of these benefits, just generally of smaller magnitude. The blood pressure effect, I would say, is equivalent, but the LDL cholesterol tends to move in the opposite direction. So now if we have agents for the treatment of diabetes that have all these pleiotropic effects, if you will, on risk factors, what are their consequences on those cardiovascular events? So here we see now in a meta-analysis by Darren McGuire published last year of the Sglt2 inhibitors used in patients with type 2 diabetes at high risk of cardiovascular events. In about 47,000 patients overall, we see a 10% reduction in the 3-component MACE of CV death, MI, and stroke. If you look specifically at CV death, you see a more impressive 15% reduction, but the real story with Sglt2 inhibitors was the reduction in hospitalizations for heart failure. Very impressive, consistent, robust, 30% reduction overall. If I do the same meta-analysis, which has been published by Kirstensen et al., for the cardiovascular outcome trials of patients with diabetes at high risk of cardiovascular disease now treated with GLP-1 receptor agonists, you get about 56,000 patients with a 13% reduction in the 3-component MACE. CV death is down by 12%, and hospitalizations for heart failure are good news, moving in the right direction, but a much smaller benefit, about 9%. If I exclude those studies that are with the non-human, in other words, the exenatide or lizard-based GLP-1, there's about 35,000 patients with a MACE reduction of about 17%. I want to dive into 2 of the most recent studies, one of the longest, and one of the shortest. Rewind with almost 10,000 patients with a follow-up of almost 5.5 years, a really well-conducted study with high rates of adherence, shows the following: a 12% statistically significant reduction in the primary outcome of death, stroke, and MI. If you break down the component endpoints, you see there was really no significant reduction in death, all-cause death, CV death, all-cause death, or MI, but the benefit is significant with non-fatal stroke. If I move now to one of the smallest studies, which was Pioneer 6, which is now the first GLP-1 analog with oral GLP-1, with very similar inclusion criteria, what we see is now a 21% reduction in MACE, but did not reach statistical significance. This was because of a small number of events. And the component endpoints shown here are CV death showed a 50% reduction, but one should interpret this with caution given the small number of events. If I then look at one specific endpoint, stroke, I see that of all of the GLP-1 receptor agonists, overall, it's about 16% reduction in stroke. And reminding you of some of these overall data for the other endpoints, this is probably the most robust finding and most consistent finding of the GLP-1 receptor agonist cardiovascular outcome trials. So what does this all mean clinically? Well, this very busy slide is probably too busy for us cardiologists. What we're going to focus on very specifically is right at the top. In type 2 diabetes, drug naive with already present cardiovascular disease or at high or very high risk of cardiovascular events, really one should be using one of these two classes, an Sglt2 inhibitor or a GLP-1 receptor agonist. Notice this is in monotherapy even before the addition of metformin. The further recommendation that is now consistent across both sides of the Atlantic is that in people even on metformin with the same presence of disease or high risk of disease, these two same classes should be used, the important development being irrespective of A1C. Let me end with the fact that high rates of CVD remain a major burden in patients with type 2 diabetes. The cardiovascular outcome trials of GLP-1 receptor agonists in this group support the use of this class irrespective of A1C. And one of the more consistent and robust benefits appears to be a reduction in stroke. Thank you very much.
Thank you for joining me for this talk entitled The Science of Obesity. Where might this lead clinical practice? I'm Dr. Sean Wharton. I'm an adjunct professor at McMaster University and York University and the medical director of the Wharton Medical Clinic. Obesity is a pandemic. It affects between 650 million to 1 billion people across the globe and 9 million Canadians. Excess adipose tissue causes or exacerbates multiple medical conditions, including diabetes, cancer, and COVID-19. This morbidity and mortality is primarily due to the dysfunctional white adipose tissue causing inflammation. This can affect almost every system in the body. So how good are we at treating it? Unfortunately, we've not been very effective for a long time, and only recently are we getting a bit better. This Canadian study looked at lifestyle management, a healthy diet and activity prior to the advent of effective treatments. We found 7 patterns of weight loss. Let's focus on the purple and yellow lines, which represented weight stability or minimal amounts of weight loss of only 2.3%. This made up 2/3 of the patients. So most patients cannot achieve significant weight loss with just lifestyle interventions. But do we need greater weight loss? Sure we do. Let's look at the improvements we get in medical conditions with weight loss. We get some diabetes prevention at 3%, but more at 10% weight loss. Many conditions need up to 15%, such as diabetes remission. So more weight loss is better. Our challenge in terms of getting greater weight loss is our lack of understanding of the complicated science of obesity. The pathogenesis involves biological, genetic, psychological, and environmental factors. Body weight is meticulously regulated by the brain, an organ we barely understand at the best of times. The science of energy homeostasis is rooted in our genes. If our genes drive up even a small surplus of calories, less than 1%, that can easily result in elevated BMIs. Unfortunately, once that weight is there, biological defense mechanisms kick in and keep the weight elevated. The gut-brain connection plays a major role here. Hormones such as GLP-1, PYY, leptin, and ghrelin are all generated from the gut, and then they head up to the brain. And if they are dysregulated, either not enough of them or too much, this can lead to elevated weight. So what does this science lead us to conclude about obesity? This slide is likely the most important slide in my slide deck. The science tells us that obesity is not caused by overeating, but that instead, overeating is caused by obesity. This is not just a play on words. It has been shown in many studies that overeating cannot cause obesity if you do not have the neurochemical and genetic profile to develop this elevated weight. On the other hand, if you have genetic and biochemical setup for obesity, this leads to hunger, cravings, and overeating, leading to elevated weight and to obesity. Our current understanding of the brain and the gut hormones have helped us design treatments that actually work: psychological intervention, pharmacotherapy, and bariatric surgery. Based on this science, there are now options for pharmacotherapy. We have some medications approved in Canada and some emerging medications. Liraglutide was the first effective weight management medication to come to Canada in 2015. For the first time, patients got some relief from their obesity with this daily injection. They got up to 9% weight loss in the completers. The primary side effects were nausea, impacting up to 40% of patients. This was both tolerable and also a transient side effect. We did a real-world study looking at liraglutide and got promising results, up to 7% weight loss. We also saw nausea as a side effect, but we also noted that constipation was a major challenge for many of our patients. The second effective drug to hit Canada was the combination Naltrexone and Bupropion in 2018, again impacting the brain. Overall, we're seeing about an 8% weight loss here and improvements in cravings, which can be a real problem for many patients. The main side effect was, again, nausea. This medication cannot be used in patients who have a seizure disorder or those on opioids. So far, the two medications that we have in Canada have not pushed past that 10% weight loss mark. Emerging medications include semaglutide 2.4 milligrams, a once-weekly GLP-1 analog, as seen in this recent trial. Here, we finally cracked the 10% average weight loss range, getting to almost 15% weight loss with semaglutide 2.4 milligrams. Most impressive was that 1/3 of patients had greater than 20% weight loss. We've never seen that kind of result in a non-surgical trial. The most common side effect was again nausea, similar to that seen in other semaglutide trials. Another emerging medication is Amlin, again targeting the brain, decreasing appetite and increasing the feeling of fullness. The monotherapy trial here shows 10.8% weight loss, but the compelling studies are looking at Amlin combined with a GLP-1, and this phase 2 trial showed a promising 17% weight loss. Early days, but still very promising. Nausea and GI upset were again the main side effect. The newest emerging medication is the molecule tirzepatide, a dual agonist of GIP and GLP-1, treating both diabetes and also weight. Most of the clinical trials with tirzepatide are in patients with diabetes. The studies represented here in blue. But weight management trials in patients with and without diabetes, seen here in purple, are also pending. So what can we expect from tirzepatide? In patients with diabetes, this phase 2 trial showed 11% weight loss. We know that patients with diabetes lose less weight than those without diabetes, likely due to metabolic adaptation, a phenomenon we have yet to understand. Therefore, we can expect even greater weight loss with this molecule in patients without diabetes. The main side effect of tirzepatide was, again, nausea and also some GI side effects. In conclusion, the science of obesity is complex and is driven by the brain neurochemistry that interplays with genetics and the environment. The gut-brain connection is the main target of many new effective treatments. Overall, treatments for obesity are still in the limited stage, but increasing in a rapid manner as we gain more scientific knowledge about this condition. Thank you very much for your time.
Well, thank you very much to our three speakers for those really wonderful presentations. Just fascinating to try and understand the cardiovascular protective effects of GLP-1 receptor agonists. Great mystery of metabolism to join the great mystery of how bariatric surgery actually exerts its beneficial effect. So I'm sure there's going to be a lot of questions about that. But I have I'll start off with a clinical, just a comment, and I think this, and then a question. And it's really directed to both Dan and Mansoor. Don't worry, Sean, we'll get to you in a few minutes. But the comment is that it appears from meta-analysis and systematic reviews that the cardiovascular relative risk reduction of GLP-1 receptor agonists is sort of in the low teens right now. And it's important to contrast that, for example, with the 30 to 50% relative risk reduction from statins and similar risk reduction from blood pressure reduction. And so one really needs to keep that in mind and has to be figured into the equation of when and where to use these agents. The question I have really is related to class effect versus whether there are differential effects of the various agents. And maybe, Mansoor, you might be able to answer this first, but over the next 5 years, with the clinical trials that are underway of GLP-1 receptor agonists and cardiovascular hard outcomes, do you think we're going to be able to figure that out or get some data over the next few years to answer the question as to whether one or another agent is more effective in cardiovascular risk reduction?
Thanks, Gary. Let me just add that, all of these cardiovascular outcome trials were really done on excellent background therapy. Baseline blood pressure control, the use of, best-in-class ACE inhibitors, ARBs, et cetera, were really high. Statin background use was really high. So while the event rate reductions may appear modest, they're on the background of sort of optimal medical therapy. With regards to differences between the class, my view of this is that they correlate reasonably most closely with weight loss. There is some divergence as to whether they always correlate with metabolic effects, but my read of the literature is that the more potent the weight loss, and often accompanying that, but not always, are equivalent glycemic effects, blood pressure effects, et cetera, the more likely are the cardiovascular reductions. And I'll let Dan offer his thoughts on individual agents.
Dan, interested in your thoughts about comment and question.
Yeah, first of all, I think Mansoor made a very good point. So the numbers that you're quoting, Gary, are all relative. If I did a statin trial today on top of Sglt2 inhibitors and GLP-1 receptor agonists and antiplatelet agents and maximal hypertensive therapy, I think you'd get very different numbers for a number needed to treat. So I think it's all relative depending on the era that you did the trial in and what the background therapy was. I don't think those comparisons are really valid. I think it's really difficult to pin the cardioprotection, on a correlation with weight. Weight is certainly a readout for a very effective GLP-1 receptor agonist. But I'll take you back to albiglutide. It's a GLP-1 receptor agonist that reduced MACE by about 25% reduction in myocardial infarction. And the amount of weight loss that you got with albiglutide was about as much weight loss as you'd get if you skipped your last dinner before you went in for the weigh-in the next morning in the clinical trial, almost none over the trial length. So it really shows you we don't really understand the mechanisms that are fully responsible for the cardioprotection. But weight loss is clearly a readout for a very effective GLP-1 receptor agonist. So I think having more weight loss, more glycemic reduction, you're probably going to get good cardioprotection.
So I have a question for Sean. I mean, that was a fantastic talk, and it's always great to see the science behind obesity, and this has come out loud and clear from the guidelines that you co-chaired, that we really should certainly stop the patient blaming and the person blaming that's been rampant in obesity. But what would you say to the people who would go, well, these therapies you're talking about, sure, they're effective, but they're expensive. And for some of our patients, we may need to use combination therapies, and then it's really expensive. And then when you stop the therapies, the weight comes back. So is this really money well spent for the system or for a given individual? So Sean, what would you say to someone who asked you that?
Terrific. That's a great question, and we get it on a regular basis. So everything in obesity is new. It's been about 20 years. So if we look at the three pillars that actually treat it, bariatric surgery, we didn't have that 20 years ago here in Canada. It's only in 2007 that we actually got the funding for it to actually do it. So it's been about 13, 14 years we've been doing it properly. The psychological intervention piece, we weren't doing that for weight management 20 years ago. The medications that we're using right now, we didn't have. So we had zero 20 years ago. This whole field is new. Everything is expensive. Everything is different and new. I think we need to advocate for it. And the reason why everything is new is because of bias. People are biased against elevated weight. People living with obesity think it's their fault. We haven't done research. We should have been researching this for the past 100 years, not for the past 20, 30 years. And in a much better way, the brain neurochemistry, et cetera. So a lot of it is bias, and I think bias drives the inability for the insurance companies and for the government to look at appropriate pricing. So people living with obesity need to advocate. I can't advocate because they don't care. If a doctor goes to the government and says, we'd like this drug covered, but they care if their voters go and say, this is not okay, and to the insurance companies. So bias has caused this problem, and advocacy is going to make it better.
Excellent. Thank you. Thank you, Sean. So we've got some great questions coming in, and I'm going to ask our panelists for relatively brief answers so that we can try to get through these questions. Dan, I think this first one is probably for you. Can you comment on use of GLP-1 receptor agonists and hereditary angioedema? Is it safe to use?
I have no idea.
I was hoping you would. When I read the question, I didn't know why it was being asked. Does anybody else on the panel have anything to add?
So
there's an anti-inflammatory mechanism, and this is a C1 esterase deficiency. Maybe Mansour knows, but I don't think it's really been carefully studied.
No, there are anecdotal. I've been asked this question before. There are anecdotal cases of edema occurring with the use of GLP-1 receptor agonists, but it does not appear to exacerbate people with hereditary angioedema.
Okay, excellent. Thank you. There's a question here. Can you please comment on the role of circadian variation in incretin expression and its dysregulation or mismatch with timing of meals in the pathophysiology of obesity or type 2 diabetes? So maybe I'll start with Dan, and then Sean, you may have something to add with that as well.
Yeah, so there is really nice data, and Pat Brubaker in Toronto is the world's leader in the circadian control of GLP-1 secretion, and that happens in mice and humans. And it does correlate with insulin secretion and glucose control. What we don't have is the corresponding data that says it makes a difference when you take pharmacological GLP-1. And we know that most of the drugs we use today are present 24 hours a day, and there isn't really much chronobiology in their mechanism. But certainly there is some rhythmicity to the normal physiological secretion and action of GLP-1 beyond the pharmacology.
Okay.
Yeah, and I would add to that that when we're looking at people living with obesity in the ranges of BMIs of 45 and 50, and there's a dysregulation, then what are the actions of the rhythms? What are the circadian rhythms? When are the GLP-1s working and not working? Sometimes it seems like they're not working at specific times, or they're not working at most times. So I think we're going to start finding that these patterns are different based on who we're actually looking at.
Question, next one for Mansoor, actually. The greater renal impact of the GLP-1 receptor agonists appears to be albuminuria based. So do you think that this is an anti-inflammatory thing, or what do you think is going on?
So all of the cardiovascular outcome trials have looked at composite renal endpoints. And while these have been a major feature of the SGLT2 studies with really good data on nephroprotection, as we like to say, they've been underappreciated with the GLP-1 receptor agonists. And there are emerging data that there is some retardation of the progression of diabetic nephropathy in this group, but it mostly is an albuminuria effect. Although there are some data about the changing the rate of descent of the GFR fall. And as to mechanisms, I mean, the agents appear to have modest effects on renal flow. We're going to learn a little bit more about this, as there are studies specifically in patients with nephropathy examining renal mechanisms. I don't know whether this is an anti-inflammatory effect. I would, I'm not as expert about the mechanisms of proteinuria in diabetes. I think it's maybe partly inflammatory. I don't think that's the major mechanism. Dan may have other thoughts.
I think I'll jump in and ask a question that's come in through the chat. By the way, the question is just coming fast and furious here, so you can see how interested obviously the attendees are. So this one, because it builds on a little discussion we had a few minutes ago, could you please comment on the absolute risk reduction in cardiovascular events with SGLT2 and GLP-1 receptor agonists compared to other CV medications? And so granted, the comments that were made earlier about a different era, and obviously these drugs are being added to much more intensive statin therapy, antihypertensive therapy. The fact is that they do provide the protection at the level that is described based on addition to those therapies. But as we heard last night, we have many options now. We can target coagulation and synthetic EPA compounds, and so how does one? I think I'll ask Mansoor this question: how does one weigh up these relative benefits of all these additive therapies, and then which one do you choose? And you're adding up costs. Nothing comes without side effects, so it's confusing.
So I tried to sort of be as succinct as I could in my 8-minute presentation, but in patients with type 2 diabetes at high risk of cardiovascular disease or with established cardiovascular disease, I think the data are unequivocal that you should be using one of these two classes. The MACE effects overall, that 3-component endpoint, are similar, but in my view, they are better for GLP-1 receptor agonists, driven by atherothrombotic events. But if you had a patient at risk of heart failure, then you're better off by using an SGLT2 inhibitor first. I think those numbers are very meaningful. They're very consistent. And we've begun to see it clinically. There's one thing to read about clinical trials, but now with the practice, both in the diabetes community, in the cardiology community, we're really starting to see people having less symptoms, doing better, not being admitted with recurrent events. I think this is translating in people who are beginning to use these drugs. Patients really like them.
Thanks. Did you want to comment on that, Dan?
Yeah, we don't have the evidence for this, but I'll just be provocative. It's worked for me for 40 years. Most people should be on both of these classes of drugs. Obviously, we don't have the definitive CVOT, RCT, But as Mansoor mentioned, they're complementary. We're covering the heart failure piece, we're covering the stroke piece, we're covering the atherosclerosis, piece differentially. And there's really no reason not to use both of them. And in 4 or 5 years, we'll have really good generic versions of all of them. So I think if I put 100 cardiologists in the room who are patients, I think 95% of them would choose to be on both of them to protect all of the various issues that we've discussed.
And if I could add to that, towards the end of February in Circulation, there was a real-world analysis that was published that looked at the addition of an Sglt2 inhibitor on top of existing GLP-1 receptor agonist use and demonstrating further reductions in cardiovascular endpoints compared to adding something else to that.
There was also a brilliant editorial written. What's her name? I can't remember her name. But yeah, it was a really important point made. Use these drugs together to protect additional risk.
Right, time to act for sure. I have a question here. I'm going to direct this one perhaps to Sean, and of course, Mansoor and Dan, please pipe in as well. It's a question around weight loss and HFpEF, heart failure and preserved ejection fraction. So are there any evidence suggesting that there may be cardiovascular benefits of weight loss, particularly in HFpEF?
Right. So I'll let Mansoor really take this, but definitely that's the area that most people want to actually look at. We know there's going to be benefit in fatty liver and obstructive sleep apnea, very clear things that diabetes and so obesity and these things are connected. Preserved ejection fraction heart failure is the really big and fascinating area. It may have been underdiagnosed, so maybe almost everyone living with obesity may have a degree of it and really needs to work on. That's why their disease and their COVID-19 morbidity and mortality may be such at a high rate. So I'm really looking forward to the trials, and they're doing the trials. Mansoor can speak to it.
Yeah, we have the early data with a HFpEF with SGLT2 and SGLT1 combination drug in recently hospitalized patients with heart failure. Looks very promising. I think Sean hit it beautifully, is HFpEF in the presence of obesity is a very difficult diagnosis to make. Everybody has exertional dyspnea. I think the rigorous standard is an admission to hospital that responds to diuretics with evidence of pulmonary edema. That's kind of unequivocal because you can't go about doing invasive hemodynamics or even sophisticated imaging studies, although the detection of diastolic dysfunction, elevated left atrial pressure, coexistence of atrial fibrillation are all signs that your patient likely has HFpEF if their systolic ejection fraction is preserved. Now the evidence of weight loss per se hasn't been rigorously examined, but I think most, the 100 cardiologist rule that Dan pointed out, you're going to get symptomatic benefit. It remains to be proven whether you're going to get mortality benefit from weight loss alone. I think SGLT2 inhibitors have a nice side effect of weight loss, but my own belief is their mechanism is this natriuresis, osmotic diuresis, and improved cardiorenal function.
So thank you very much, gentlemen. It's always great fun to spend some time with friends, and it was a nice way to spend part of my Thursday evening. And I encourage everyone to stay on for the next session, and I'm happy to introduce the next chairs, Professors Brian Rayner and Peter Libby.
Good evening. I'm Brian Rayner, and I'll be co-chairing this session with Peter Libby. We have 3 speakers, and I'll introduce the first 2. The first talk will be on Sglt2 inhibitors, cardiorenal mechanisms in diabetes and beyond. This would be delivered by Professor Julie Lovshin from the University of Toronto, Canada. He directs the Diabetes Complications Research Laboratory in the new Clinical Investigation Unit of the Division of Endocrinology and Metabolism. And she has a major research interest in the mechanisms of complication of type 1 and type 2 diabetes. The second speaker I'll be introducing is Professor Teresa Mcdonough, who will be talking on heart failure therapy extending the limits. She hails from King's College London in the United Kingdom, and she has a major research interest in heart failure, especially in relation to novel biomarkers for heart failure and delivery of heart failure Services. She's been past chair of the British Society of Heart Failure and past chair of the clinical section. I'd like to now hand over to Peter Libby.
So, good evening. I arm wrestled Brian for the honor of introducing my colleague and friend, Mark Pfeffer. Professor Pfeffer is very well known for both his fundamental research and his clinical investigations. He is the Distinguished Dow Professor of Medicine at the Harvard Medical School and a senior physician at Brigham and Women's Hospital, where we practice together. And he's going to be speaking to us about surprising findings from clinical trials, cardiology, diabetes, and nephrology. And the breadth of his clinical trial experience and wisdom extends across all of the organ systems that are of concern tonight. Thank you very much.
Thanks very much to the chairs and to the organizing committee. Once again, my name is Julie Lovshin. I'm an endocrinologist and clinician scientist at the University of Toronto, and I'm really delighted to be here today with all of you to review cardiorenal mechanisms of Sglt2 inhibitors in diabetes and beyond. Now, before I begin, here are my disclosures. As an endocrinologist in 2021, I feel very fortunate because we have two drug classes that are able to reduce complications in my patients with type 2 diabetes, including diabetic kidney disease, heart disease, obesity, and metabolic disease. The drug class we're going to focus in on today is Sglt2 inhibitors, and specifically focusing in on their favorable effects in the heart and in the kidney. And what better place to start than to look at the cardiovascular outcome trials that have been completed with the various Sglt2 inhibitors. As you can see from this slide, Sglt2 inhibitors are able to have favorable effects on reducing the risk for major adverse cardiovascular events, including CV death and hospitalization for heart failure. In particular, hospitalization for heart failure is where we see a very robust cardioprotective effect in reducing the risk in patients with type 2 diabetes, either at risk or with cardiovascular disease. Now, not shown on this slide is the fact that these Sglt2 inhibitors also had favorable effects on kidney outcomes. Because the cardiovascular outcome trials were designed for cardiovascular safety, they didn't necessarily enrich their population with either heart failure or chronic kidney disease, but subsequent trials have, and that's what we're going to review now. We're going to start with the kidney trials that have been completed with Sglt2 inhibitors, the Credence trial with canagliflozin, which enrolled patients with type 2 diabetes and CKD, and DAPA-CKD, which enrolled patients with CKD with or without type 2 diabetes. As we can see across the board, both of these drugs significantly reduce the risk for adverse renal events, including doubling of serum creatinine, end-stage kidney disease, and either death from renal or CV causes. And we can see that the signals were driven by renal protective effects as well as reducing adverse cardiovascular effects. So given these beneficial effects that we see with Sglt2 inhibitors, people have gone on to ask the question, well, what are the renal protective mechanisms responsible? So let's start off with what we do know, because there are a lot of unanswered questions. What we know is that this is not secondary to A1C, and we just have to turn to the results of the DAPA-CKD trial, which showed renal protection irrespective of diabetes status. We also know this is not because of weight loss or blood pressure lowering. We know that the effects occur rapidly. We know the Kaplan-Meier curves separate quickly between 3 to 6 months. So whatever mechanism's responsible has to have a rapid onset. Now, people have jumped to the idea that this is secondary to a hemodynamic effect. And that's because when we initiate Sglt2 inhibitors, we often see that little eGFR dip between 3 to 4 weeks, which suggests that it's affecting a hemodynamic effect in the kidney. And so that has therefore pinpointed the mechanisms to be centered around natriuresis. Now, there are several hypotheses out there. No one knows the single or multiple mechanisms responsible. Here's just an example of some of the more popular mechanisms. If we start on our far right, one of the pathways is known as tubular glomerular feedback. And the idea here is that because Sglt2 inhibitors cause proximal natriuresis, they deliver more sodium to the distal kidney. And this is good for the diabetic kidney because it causes vasoafferent constriction. That reduces renal blood flow, reduces pressure in the kidney, reduces hyperfiltration, and slows an eGFR decline, which is what we see clinically. There are several biochemical pathways within the kidney that have been implicated, and there's too numerous to list, but most of them center around reducing inflammation, oxidative stress, and intrarenal RAS. And finally, energy metabolism pathways have been implicated. This one's interesting because the idea here is that tubules are doing less work. They're reabsorbing less sugar, less salt, therefore they're using less oxygen, and effectively there's more oxygen available for the kidney. And that's important because hypoxia pathways, which are linked to fibrosis, are down-regulated. And finally, I can't help but be optimistic that Sglt2 inhibitors reduce common risk factors for chronic kidney disease, but that can only be good for the diabetic and non-diabetic kidney. So we're now going to transition into Sglt2 in the heart, and there have been 2 recent heart failure studies that have been completed with Sglt2 inhibitors, including DAPA-HF with dapagliflozin and EMPEROR-Reduce with empagliflozin, completed in patients with heart failure and reduced ejection fraction, again, with or without type 2 diabetes. And as we can see in the primary outcome, both of these therapies were consistent with reducing a primary composite of reducing the risk for CV death or worsening heart failure, irrespective of diabetes status. And they also had favorable effects on renal outcomes. So just like the kidney, people have gone on to ask the question, well, what are the cardioprotective mechanisms of Sglt2 inhibitors? Again, here's what we do know, starting in panel C. We know that the mechanisms must be rapid because the Kaplan-Meier curves separate quickly. We know they're occurring independent of other CV therapies because Sglt2 inhibitors are additive to other diuretics that are already being treated for our patients with heart failure. Finally, in panel D, unlike the kidney, there are no Sglt2 channels in the heart. So a direct cardiac mechanism is a bit hard to envision at this point, and we know this is not occurring because of glycosuria. As we know, the heart failure studies had protective effects in patients with and without type 2 diabetes. So again, we do not know the mechanism for cardioprotection with Sglt2 inhibitors, but here are 4 of the more popularized theories. Starting in panel A, we know Sglt2 inhibitors are natriuretics and that they reduce plasma volume. This could lead to less LV volumes and less remodeling. Panel B, we know that they increase hematocrit, and this could be secondary to increases in erythropoietin, which could increase cardiac tissue oxygenation. In panel C, many endocrine and biochemical pathways have been implicated. The one that I think is under-investigated are the effects of Sglt2 inhibitors on sodium hydrogen ion exchangers. And finally, in panel D, we know that Sglt2 inhibitors modify traditional cardiovascular risk factors, and I can't help but be optimistic that that's a good thing for the failing heart. So in the landscape for 2021 for Sglt2 inhibitors, we've seen the translation of Sglt2 inhibitors beyond type 2 diabetes and into the non-diabetic kidney and into the non-diabetic failing heart. And I look forward to seeing upcoming data for Sglt2 inhibitors and looking at further translation of these drugs. I'm going to end there and thank you for your attention and look forward to answering your questions in the Q&A panel. Thank you.
Thank thank you very much for the invitation to speak at the meeting, and sorry I can't be there in person. I join you from London, albeit in the same time zone. In terms of talking about extending the limits of heart failure therapy today, I'm going to cover some advances in the field of chronic heart failure with reduced ejection fraction, and I'm going to confine myself to drug therapies for the heart failure syndrome itself and one of the comorbidities. In terms of extending heart failure therapy further, we have to remember we have a very high baseline to improve upon, and that is, of course, the class 1A treatments that we use for all patients with heart failure with reduced ejection fraction: ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, because of their wealth of evidence accrued over the last 25 years that these drugs convincingly lower all-cause mortality, cardiovascular mortality, hospitalizations for heart failure, and improve patient symptoms and quality of life. The first extension, of course, we had to this blockade of the renin-angiotensin-aldosterone system was with the neprilysin inhibitor combined to an angiotensin receptor blocker, sacubitril/valsartan. Neprilysin, of course, breaks down the natriuretic peptide hormones, the good guys in heart failure that cause vasodilatation, natriuresis, and offset the augmentation of the renin-angiotensin-aldosterone system and sympathetic nervous systems that are in overdrive in heart failure. So the prototype angiotensin receptor blocker, neprilysin inhibitor, sacubitril/valsartan, was of course trialled in the Paradigm HF trial in over 8,000 patients with heart failure with reduced ejection fraction, and it was compared to conventional therapy with enalapril, and of course showed a reduction in cardiovascular deaths, all-cause mortality and hospitalizations, roughly a 20% relative risk reduction on top of ACE inhibitor therapy. And of course that has now made it into most international guidelines in terms of a position of switching from an ACE inhibitor to sacubitril/valsartan if patients remain symptomatic with heart failure with reduced ejection fraction. So where might that be extending in the future? Well, looking at two trials that have been published recently, we might see it being used in the future in patients who are naive to ACE inhibitors. The Transitions study looked at randomizing patients admitted to hospital with heart failure, some of them were ACE naive, to initiation of the sacubitril/valsartan in hospital compared to initiation post-discharge. And you can see from the side effect profile of these two strategies, they seem to be similar, so there is no adverse effect in terms of hyperkalemia, hypotension from trying sacubitril/valsartan in hospital. And in the Pioneer study conducted in the United States, in just under 1,000 patients, patients were randomized in hospital to sacubitril/valsartan use compared to enalapril. The primary endpoint was a reduction in N-terminal proBNP, and that happened with more efficacy with sacubitril/valsartan. Again, with this strategy, adverse events of worsening renal function and hyperkalemia and hypotension were similar in the enalapril versus the ARNI group. And looking out to 8 weeks, patients who were randomized to sacubitril/valsartan had a lower incidence of heart failure hospitalizations and cardiovascular deaths. So we may see ARNI going from a switch therapy to initiation in ACE-naive patients in the near future. I suppose the big extension is what to do after you're already established on an ACE or an ARNI, a beta blocker and an MRA. And undoubtedly the recent trials with the sodium glucose cotransport inhibitors have given us some hope here for additional therapies. These drugs were of course tried first of all in patients with type 2 diabetes who had cardiovascular disease or were at cardiovascular risk. And a consistent finding from these trials was that these drugs reduced heart failure hospitalizations. This then led, of course, to the large outcome trials in heart failure with reduced ejection fraction itself, starting with DAPA-HF with dapagliflozin. Dapagliflozin clearly reduced mortality, cardiovascular mortality, hospitalizations for heart failure on top of conventional therapy with ACE inhibitors, beta blockers, MRA, and indeed some patients who were already on an ARNI. This was followed up by a trial with empagliflozin, Emperor reduced, which reported last year. Again, empagliflozin reducing a combined endpoint of cardiovascular deaths and hospitalizations for heart failure. This time, no effect on cardiovascular deaths, but a significant reduction in heart failure hospitalizations. And most recently followed up by a trial in patients with worsening heart failure with sotagliflozin, which of course blocks Sglt2 and Sglt2 receptors. This trial drug started in hospital for patients with worsening heart failure and again reduced cardiovascular deaths, heart failure hospitalizations, and urgent visits for heart failure. So Sglt2 inhibition is undoubtedly going to have a major place in heart failure management for patients with a reduced ejection fraction in the future. But what about some newer targets? Well, there's been a lot of interest in manipulating the guanylate cyclase pathway in heart failure. The guanylate cyclase pathway ends with cyclic GMP, which is a vasodilator. And a potential way of manipulating that pathway is by augmenting soluble guanate cyclase. That's been looked at in heart failure, and there now has been a large outcome trial with the prototype soluble guanate cyclase inhibitor vericiguat in over 5,000 patients with heart failure with reduced ejection fraction on optimal medical therapy. The drug does seem to confer benefit in terms of a 10% reduction in cardiovascular hospitalizations, heart failure hospitalizations or cardiovascular deaths. The main effect is on reduction in hospitalizations. So that looks promising. In addition, we have an extension back to the future in heart failure, looking at inotropes, and this time a novel inotrope, omecamtiv mecarbil, a cardiac myosin activator that promotes the binding of actin and myosin into a very strongly bound force-generating state. It's been looked at in over 8,000 patients with heart failure recently in the GALACTIC-HF trial, and once again we see an 8% reduction in a composite endpoint of cardiovascular deaths or time to first heart failure event. Again, no reduction in cardiovascular deaths, but an improvement in the composite endpoint, maybe again showing some hope for the future for this inotrope in chronic heart failure. And lastly, a treatment for comorbidities. Morbidity is extremely important in an aging heart failure population. The mean number of comorbidities is 5. One of the best studied, of course, is iron deficiency, occurring in about 25 to 40% of all patients with heart failure. And this is iron deficiency with or without anemia. We know from smaller studies that intravenous iron improves effort capacity and quality of life in patients with heart failure. But now we have a larger outcome trial using intravenous ferric carboxymaltose in patients admitted to hospital with heart failure who have iron deficiency, and that's iron deficiency with or without anemia. The drug seems to again improve a composite endpoint of heart failure hospitalizations and cardiovascular death, with the majority of the effect here on reduction in hospitalizations for heart failure. So if we look back over the last 25 to 30 years with inhibition of the renin-angiotensin and aldosterone systems, and then more recently trials with devices, sacubitril/valsartan, and We see major reductions in heart failure mortality for patients with reduced ejection fraction. And yet hopefully that number is going to be driven further and further down by the new extensions to the indication that I've shown you today. But we've not stopped. We've still got work to do. There's probably still a modifiable risk of between 12 and 20% in terms of excess mortality and cardiovascular hospitalizations to deal with. Thank you.
I'm delighted to be at the Limits in Canada. I only wish I was with you in Toronto. It was looking forward to a fun trip. At the Limits has always been a great experience where we actually try to do just that, take things to the limits. My talk today, surprising findings from clinical trials in the fields we cover, is really a broad platform, and it's not a specific with this data point and that data point, but to give you an overarching view of the importance of clinical trials, not just clinical trials, but outcome trials. Obviously, I have some disclosures, but I think they won't influence any of what I'm about to say. Experience will influence it. Let's start with the biggest surprise, an early surprise, which impacted the cardiovascular community immediately. We were all trained to stamp out every arrhythmia. And if you're a cardiologist in the audience and you were practicing before this, and you were in training, you were called the consult to get rid of these funny beats because we knew from the epi that they were associated with bad outcomes. And we had drugs that could make the bad beats disappear. So the trial was done, funded by the government, the NIH. What happens when we make the bad beats go away? Let's show that we improve survival. So the outcome isn't arrhythmias. The outcome is who's alive, who's dead. And wow, what a surprise this was. You would rather be on placebo. Now, I say that lightly, but that was an amazing discovery. And think of all the people we tackled as they left the hospital to put them on these kinds of drugs. And think of all the lives saved by learning that we were wrong. A humbling experience. Now, cardiology has a lot of humbling experiences. Here is one that I would have guessed, use an inotropic agent, make the failing heart a better pump. And the surrogates were all aligned. Yes, ejection fractions improved. Yes, cardiac output's better. Yes, yes, yes. Now let's give this long-term, not for the surrogate of ejection fraction or exercise performance, but for survival. And once again, you'd rather be in the placebo group. This wasn't done to show that. This was done to show the opposite. Wow. And it wasn't just only this inotrope. There were 3 that were tested. And each time, you'd rather be in the placebo group. Humbling, humbling, humbling. We're still in the 1990s. Okay, sometimes surprises are the opposite. Rather than stimulate the heart, let's inhibit. Let's use a neurohormonal inhibitor. Let's use a beta blocker. Well, I had nothing to do with this. Surprise, reduction in the risk of death. Now the endpoint is deaths. A third reduction in your risk of death on top of the ACE inhibitors that had already proven a benefit. A pleasant surprise, but only because the outcome trial was done. So we can find many areas where the surrogate looked good, but the surrogate didn't predict outcomes. And I'll only talk about a few, but in each case, you could never know safety from the surrogate. So humbling experiences, humbling. We need the trials. Probably our best success story in cardiovascular medicine was the statins, and no one takes credit for this. It's a whole field, an amazing field. But what was so interesting, each trial after discovery, marched to a new target population, one that hadn't been studied before. Beats placebo in high risk, beats placebo in people with normal cholesterol, beats placebo in high risk prevented. Down here, let's go against placebo, but let's take a population never studied before. On and on and on, so that within 15 years, we have 26 trials, 170,000 people. Put it all together, we could be sure we're helping, and we're not hurting. How else can you know that? But this field was so mature that we had trials all levels of risk. Even in this field, we can show where we didn't help people. Now I bring in my renal community. Sorry, 2 well-done trials in dialysis. Drug which helped people, effectively lowered cholesterol, didn't help in terms of events. Can even bring in heart failure, same story. Okay, surrogate, HDL. Let's raise HDL. Well, go for a walk, red wine. Maybe you can raise it by 2, 3. How about a 70% increase? And how about throw in a 25% lowering of LDL? Great surrogates. Well, study was done not for lipids, but for mortality, for outcomes, and more people died on the drug, on torcetrapib. Wow, humbling experience. The renal community, you're not isolated from this. From the very beginning, normal hematocrit study, people on dialysis, get the hematocrit is being treated in everyone. Let's bring it to normal, and people didn't benefit. Okay, how about non-dialysis? We did treat against placebo. We found no benefit. We found more strokes. Red HF in heart failure, anemia, treat, raise hematocrit, clearly effective at doing that. And when you looked at the 2 of them, both populations in the treat-like population, a 2-fold risk of stroke. Is that definitive? Hard to prove safety definitively, but wow, what a message. 2 studies. Surprise, surprise, surprise. The diabetes community, you're not isolated from this. You've been using drugs to treat the hemoglobin A1C, never associated with an improved cardiovascular outcome. Never. So much so that when safety became an issue, we first started getting major cardiovascular trials to prove safety, not even to prove effectiveness. And the definition of safety didn't have heart failure. I showed 2 wows from the 2015, 2016. Now we have a whole string of wows. But let me just show you how that was taken over. The discovery was by accident, that Sglt2 inhibitors reduced heart failure and improved cardiovascular outcomes. Taken over by the heart failure mafia, and suddenly we see that they improve heart failure events, and you don't even need diabetes. Can I say that again? You don't even need diabetes? Let me say that even louder. If you relate it to reduction in hemoglobin A1C, you don't see the effect. So we fell on this by accident. It was a discovery, and then the outcome trials. Now back to the renal community, and hooray for the renal community. Same accident, make people do outcome studies, and now we're seeing better renal effects. Surrogates, take it over, do major clinical trials, and the renal community is now showing large studies, major differences on hard outcomes. I'm just showing one, here's another, and that's because the 2 speakers before me were handling these topics and handling them very well. But my point is, and I'll end with that, we need the outcome trials. I don't care what got you to the point of being enthusiastic enough, but then you need to prove the risk and the benefit. and then we need to implement it in order to improve public health. So, surprises, yes, they can be happy surprises, they can be sad surprises, but the only way to find out is to do the studies. So thanks for your attention, and let's keep going at the limits. Pushing the limits is how we're going to improve public health and learn more. Thank you again.
Well, what a fantastic trio of trialists educating us about the limits. Now, I'm a general and preventive cardiologist, but like all cardiologists, I have to practice heart failure without a license. So let me pick the brains of my heart failure colleagues. The hospitalized patients that I see, I reach the limits. I try to stack on neurohumoral blockade. I try to lower the blood pressure, and I'm stymied because the renal function begins to deteriorate, and the nurses will hold the medications overnight because they say the blood pressure has become, in the argot of our housemen, our residents, soft. So advise me how I'm supposed to initiate guideline-mandated, proven therapies when the renal function is limiting and when the blood pressure is limiting. Not to speak of heart rate with the beta blockers.
That'd be you, Teresa.
Okay. Yeah, it's a difficult balance between the devil and the deep blue sea, and I have to do this every day as well. I think the first thing, I hope not to offend any renal colleagues on the line, is not to be too worried about rises in creatinine. To decongest the patient, I'm more worried about low blood pressure and deteriorating renal function. But to decongest the patient well, not to worry too much about small changes in creatinine. Use digoxin to help if the blood pressure is low still, get the blood pressure up a little bit, avoid IV inotropes. But yes, it is difficult, yeah. That's my thought. I haven't got any clever answers.
Peter, may I jump in?
Sure.
When I first started, of course, we were starting with Captopril. The worst thing for a patient that we had on therapy was to come into the hospital because somebody wrote, "Do not give if blood pressure." Yeah. And you'll find people don't get any of the medications, and that carries over to today. So, what number are we looking for? How about talking to the person? If they're talking to you and they're not dizzy and they're up and around, I'm not so worried about what the sphygmomanometer says.
Right. Julie, what's your advice to the general cardiologist when faced with limitations in heart rate, creatinine clearance, and blood pressure?
Well, I guess I just start off by saying that, obviously I'm not treating patients in this category as an endocrinologist. I think, I guess in terms of SGLT2, I think what's remarkable is that their diuretic and blood pressure lowering effects are additive, if not synergistic, with existing diuretics that they would already be treated with. Of course, so you definitely have to be careful with blood pressure. There doesn't appear to be an effect on neurohormones. So with SGLT2 inhibitors, there's no counter activation of RAS or the sympathetic nervous system. So I think we don't need to be as cautious in terms of compensatory tachycardia. That would be my endocrinology 2 cents worth.
So as long as I have an endocrinologist on the line, there's a question from our delegates. In Paradigm, the post-hoc analysis demonstrated a reduction of 30% in the incidence of new cases of diabetes. Can you explain that? It says sacubitril valsartan treatment.
I know there's some theories regarding valsartan and effects on pancreas, etc. I don't have an explanation. I don't think anyone does, but there are lots of theories in terms of valsartan having specific effects on insulin and pancreatic function.
So, Mark, I learned that you stimulate erythropoietin with the SGLT2s, but you did the TREAT study, which actually showed a signal for hazard of the increased stroke. So is this going to raise its ugly head someday with?
Well, I heard Julie say that, but if you're naturally raising it, maybe you're making the kidney happier. So that's different than giving industrial strength doses. But I was intrigued by that. I have to say, I was on a safety monitoring committee for one of the big trials, and you get a book A and B, and you go to the meeting to find out what it is, but you go right to the labs to look to see what's A, what's B. And if you look for hemoglobin A1C, you won't see it. But if you look for hemoglobin, boy, so it's a major change. It's not a little change, and it's not subtle.
Okay. So, Brian, what's your take on this trio of talks?
Brian's on mute.
Somebody had to say it.
And let me, while Brian is unmuting, let me invite the delegates to put their queries into the chat.
Yeah, thank you very much for these excellent talks. I mean, just on regard renal function and cardiac failure, the sodium glucose transport study suggests there may be a potential renal protective effect. There may be less acute kidney injury. So there's something mechanistically that is happening. Perhaps it's restoration and autoregulation, improved oxygenation to the kidney. So there seems to be something that is happening specifically. Understanding why these drugs help the kidney in non-diabetics, this mechanism is still operative, even though the sugar is not elevated, because you still filter sugar, you've got to still reabsorb it. If you block it, you get a natriuresis and glycosuria, albeit at a lesser degree in uncontrolled diabetes. So that's my take on the renal function. And this effect, I think, was also seen in Paradigm, where in diabetes, sacubitril seemed to be also offer some degree of less deterioration in renal function. So there's something interesting in something that blocks natriuresis in the proximal tubule.
Peter, may I say something?
Yes.
I think we're on the beginning of a new era. I said statins were the greatest thing that happened. I now see, and both speakers handle it, the Sglt2 inhibitors are the new frontier. And we're going to learn more and more and more. And it's kind of amazing. And I hope the field keeps marching down, just as the statins did. It works here, it works here. Where does it not work? And it is very exciting.
Yeah, I think in preserved ejection fraction heart failure, this would maybe the way forward. We've got no proven therapy for preserved ejection fraction. So that may be a new frontier as well.
I'm sure Mark has a thought about that, having led one of the first major trials.
Well, if you worship the p-value, you can't say that. So I don't worship the p-value. I want to find out what's best for my patient. And I think good old spironolactone is very effective in those patients.
Okay. But what do you predict with the Sglt2 inhibitors for?
I think they should be tested, and we'll find out where they don't work. Even primary prevention. It's an amazing discovery. And again, by accident. If people weren't forced to do it, they'd be on the market because they reduce hemoglobin A1C, and we'd never know all these other benefits. So I come back to my talk. We need the outcome trials, and then we need to keep doing them till we find no benefit.
Mark, do you not think, though, looking at the way that the other drugs like your in TopCat and recently with sacubitril, valsartan and Paragon, these drugs undoubtedly work up to an ejection fraction probably of around 50–55%. And I think maybe SGLT2 will work there as well. I don't know what's going to happen beyond 55%.
Yeah, and who are those people who have signs and symptoms and a normal EF? We're going to learn a lot more, and genotyping, omics, Peter, we're going to learn a lot more.
artificial intelligence, because we know that HFpEF is a market basket of different disorders, and we're going to get smarter in subtyping them. So the chat has become alive here. So how can we initiate SGLT2 inhibitors when the EGFR is in the 11 to 15 range while a patient is awaiting dialysis? What are the limits of SGLT2?
Well, that's a research question. And that's when I'm saying we don't know the limits of these drugs. I'd like to see them used at lower EGFR than the clinical trials, but that's research.
Okay, but what do I do today? Where's the limit?
Yeah,
they're not licensed for less than they're not licensed for EGFRs at that limit, so you can't use them clinically.
Okay.
Yet.
So Mark and Teresa, what order should we add the guideline-directed medical therapies in the heart failure patient? Where do we start?
That's the Teresa.
That's a difficult question.
We had wonderful discussion last night whether we should start with metformin or not.
That's exactly.
And then we heard that Dan Drucker, our host, told us that we should put every diabetic on an SGLT2 inhibitor and a GLP-1 receptor agonist at the same time. So tell us the order. What's the magic recipe?
Well, yeah, this is going to be a problem in heart failure. I think if you add everything at once, referring to the blood pressure and the renal function. But I mean, obviously, traditionally, with the original drugs, ACE, beta blocker, MRA, we added them sequentially. And I think we've now got a problem with these other newer drugs in terms of SGLT2, even if very Sglt2 or captive eventually get licenses, etc. In that many of these drugs were done not on a background of everything, so about 10% of people were on an ARNI. So I don't think we're going to be able to continue to go and add in 6 drugs sequentially, taking 3 months to up-titrate them all. I think it's going to maybe be 4 ARNI, beta blocker, MRA, and then phenotypically think, and SGLT2 in there, and then typically think of playing with other things. But those trials are not done, those trials of how to add what. Mark, maybe that's...
Well, thank you. Thank you so much. It's been a wonderful privilege for me to pick the brains of real experts, to ask all the questions I've always wondered about, but always been afraid to ask. So, Brian, maybe you can wrap up and introduce our delegates to the
I'd like to thank my co-chair, Peter Libby, and all the 3 excellent speakers for this wonderful session and discussion. And now we move on to the next session, which will be Industry Satellite Symposium, sponsored by Novo Nordisk. Thank you very much. Bye-bye.
Thank you.
Thank you.
Bye-bye.
Thank you.
So welcome everyone to the Novo Nordisk industry-sponsored satellite symposium entitled Cardiorenal Considerations in Type 2 Diabetes, How to Choose. I'm Alice Chang. You've heard from me several times already for this session, and I'm very pleased to be joined by my friend and colleague, Professor Drucker. Take it away, Dan.
Thanks, Alice. I'm relieved that you didn't call me Uncle Daniel. So we've had a great discussion tonight about should you use the SGLT2 inhibitor, should you use the GLP-1 receptor agonist, when should you use them, in which patient, should you use them both together. So we're going to have a case discussion. Alice is going to take us through her approach to the guidelines. We're going to talk a little bit about mechanisms and see if we can come to a greater understanding of the issue.
My name is Daniel Drucker, and I'm delighted to participate with Dr. Chang in drilling down on how to use these new cardioprotective drugs, specifically the GLP-1 receptor agonists. You'll note that I showed you a meeting for Insulin 100, and I encourage you to check out our website, insulin100.com. The University of Toronto is celebrating the 100th anniversary of the discovery of insulin.
these are my disclosures. So the choice we have in front of us is whether or not to use a GLP-1 receptor agonist or an Sglt2 inhibitor, which Dr. Cheng reviewed. And as you can see here in the meta-analysis for the GLP-1 receptor agonist drugs, the vast majority of these long-acting drugs do indeed reduce MACE. So are there some special things we need to think about when choosing a drug for the person sitting across from us? Well, let's drill down on some of the secondary analysis of these trials. First, let's start with the baseline characteristics. And although many of the patients, not surprisingly, were indeed similar in terms of their characteristics, there is somewhat of a wide range of dispersion around the duration of diabetes and whether or not the person had established cardiovascular disease. And reassuringly, it turns out that GLP-1 receptor agonists protect the heart and reduce MACE events in primary or secondary prevention. So let's take a look at some of the variables we might wish to consider. What about sex and age, region, for example, ethnic background, race? And for the most part, you can see the hazard ratios are to the left of the line. We see somewhat less protection in North America, which is very common in cardiovascular outcome trials, thought to be secondary to perhaps less compliance with the prescribed drug regimen. But aside from that, the drugs are widely effective across this range of secondary characteristics. What about a history of microvascular disease? Should I be concerned about whether or not the patient has pre-existing retinopathy or nephropathy or the extent of microvascular disease? And the answer again is no. You can see the hazard ratios are to the left of the line. We saw reduction of MACE events with leader in this example, whether or not the person had an extensive or modest degree of pre-existing microvascular disease. Well, what about age? Will this class of medications protect the heart in younger people or in older people? And the available data suggests that age is not really an important variable in whether or not one achieves cardiac protection. Now, of course, the number of older people over 85 was very low, and the number of younger people under the age of 35 was also extremely low. But for that matter, the common sort of groups of people that we see, perhaps 45, 50, 65, 70, these people appear to be protected with these agents. Well, how about body weight? We know that there is a range of BMIs in the people that we see in front of us. And again, we see cardioprotection across a range of BMIs, particularly in people with obesity, which I think is important given the fact that we have dedicated cardiovascular outcome trials underway in people with obesity without diabetes. So here we see an example of the expanded MACE outcome by the prior history of cardiorenal events. And the question is, what about duration of diabetes? Does it matter if I've had long-standing diabetes or if I've only had diabetes for a few years? And again, you can see the hazard ratios are uniformly to the left of the line. So we see reduction of cardiorenal events irrespective of the duration of diabetes. Well, how about cholesterol? Many of these people have dyslipidemia and they're treated with statins. Does this make a difference? And again, the answer appears to be not really. Irrespective of the baseline level of LDL cholesterol and the type of lipid-lowering therapy, again, we see cardioprotection with these GLP-1 receptor agonists. So that was the classical MACE category. What about if we drill down, for example, just on stroke and look at subcategories? And here's the data from the REWIND study with dulaglutide. And again, whether one looks at age or sex,
the pre-existing cardiovascular disease, degree of blood pressure or A1C control, we don't really seem to see a major difference in the response, favorable response to dulaglutide. Well, some people say, this cardiac protection is reflective of better glucose control and weight loss. And it's hard to rule out contributions from those two, but let's look at the Harmony outcome studies. Here we see very little hemoglobin A1C improvement over time with albiglutide and almost no body weight loss over time with albiglutide. Yet we see this profound 25% reduction in MACE, driven substantially by a reduction in myocardial infarction. So you don't seem to require excellent glucose control, A1C reduction, and weight loss to achieve these benefits. Well, people think that inflammation is important, and is the inflammation secondary to weight loss, or is there something else going on? Here's a comparison of empagliflozin and oral semaglutide, and there was very little difference in body weight after 26 or 52 weeks with these drugs, yet there was a much more substantial reduction in inflammation with semaglutide. So this is probably to some extent weight loss independent. Now, when we look at all these mechanisms, it's hard to assign specific degrees of protection to the blood vessels, to the immune system, to the platelets, to direct effects. This is still an extremely sort of difficult mechanistic puzzle. Does it matter for our patients? Probably not. As long as the drugs are safe and effective, we don't really need to know the mechanisms. We would like to understand the mechanisms if we want to make sure the new drugs preserve the benefits of the GLP-1 receptor agonists we are using currently. So what about this immune system reduction of inflammation? Here I'm showing you macrophage analysis for the GLP-1 receptor. I really can't find it there. Where do we see the GLP-1 receptor in the immune system? It's in the gut lymphocyte, the intestinal intraepithelial lymphocyte. Is that how GLP-1 reduces inflammation? Still difficult for us to tell. We see a lot of GLP-1 receptor expression in some blood vessels, in some organs, but simply put, the majority of blood vessels in most organs do not express the GLP-1 receptor. So although this might contribute to some extent to the cardiorenal properties of the drug, it's difficult to put too much emphasis on this. We continue our search trying to answer this question. How does GLP-1 work? Where are the receptors? But for the average person in front of us, when we're making these clinical decisions, it probably doesn't matter. It's more of a research question that we need to understand if we're going to make the next generation of drugs as good or better in regard to cardiorenal protection. Thanks very much for your attention.
Hello, everyone. It is always a pleasure to share the virtual platform with Dr. Dan Drucker. And I'm going to be speaking to you today about the nuts and bolts of helping our patients and around the practical issues when considering a GLP-1 receptor agonist in one of our patients. So before I go any further, these are my disclosures, having worked with many companies in diabetes as well as cardiovascular. And let's think about a patient. So here we have a 59-year-old Pakistani woman with type 2 diabetes for the last 2 years who has atherosclerotic cardiovascular disease in the form of an NSTEMI 3 months ago that was treated with PTCA and a stent. She has no known heart failure. She has the other usual suspects for risk factors. Her medications are shown to you in the middle, and relevant physical exam and labs are shown to you on the far right. The question is, what else can we do for this person in order to further reduce her risk of cardiovascular disease? And in the last 7-8 years, we have had a tremendous explosion of data in the diabetes space, looking at our antihyperglycemics and determining whether there is additional benefit to be had from them. And because of the wealth of those data, obviously guidelines around the world have updated accordingly, including our own Diabetes Canada guidelines have updated with an update to the pharmacotherapy chapter in type 2 diabetes. And in that section, it is clearly outlined the 4 types of patients in whom we should be adding antihyperglycemic therapies with proven outcome reduction. And we specifically state that those therapies should be added or substituted in order to ensure the patient is protected. But this is independent of the A1C itself. And the 4 types of patients are shown for you here: those with ASCVD, those with chronic kidney disease, heart failure, or those over 60 with 2 or more risk factors. And the outcome of interest is shown on the left. So the ASCVD group, the CKD group, the heart failure group, and those over 60 with 2 or more risk factors, and the risk factors shown here. Now, if we think about our patient, she firmly falls into the category of having ASCVD. And then it's a case of GLP-1 or Sglt2 inhibitor. And a common question I get asked is, how do I choose between a GLP-1 receptor agonist or an Sglt2 inhibitor? Now, the reality is you're likely to use both in a given patient. However, you might start with one. So the question is, how do we choose which one? Well, in my mind, if the patient also has heart failure or also has CKD, then I think in that situation, particularly albuminuric CKD, then an Sglt2 inhibitor does make sense. But in our patient, she does not have known heart failure, nor does she have albuminuric CKD. So therefore, GLP-1 or Sglt2 inhibitor both make sense. And the outcomes are shown for you here. But there's another important outcome that we should consider that is very relevant to patients, and that is, of course, that of stroke. Now, although stroke was not a primary endpoint in these studies, it was a component of the primary composite endpoint. And meta-analysis of the GLP-1 cardiovascular trials shown here demonstrated reductions in non-fatal stroke as well as reductions in total stroke, which is, of course, relevant to the patients. The other considerations are practical. So we have here the 6 antihyperglycemics available in Canada with proven data for reductions in cardiac and or renal outcomes in the GLP-1 receptor agonists on the right and Sglt2 inhibitors on the left. And it used to be that the mode of giving was different, but now they are more similar than they are in fact different, in that GLP-1 receptor agonists do exist in the oral form, particularly oral semaglutide, and of course exists in the subcutaneous form. The dosages, of course, are different. The costs are shown for you here for those who would be paying out of pocket. But another very important practical consideration is that of the eGFR. The Sglt2 inhibitor thresholds have changed considerably over time based on the clinical data, and the product monographs in Canada have updated accordingly. And now above 30 eGFR, Sglt2 inhibitor can be started. And in fact, in the case of canagliflozin, can be continued right down to dialysis. However, it's important to remember that the glycemic efficacy of the Sglt2 inhibitor class is gone when the eGFR is below 45. The benefits for organ protection remain, but the glycemic efficacy is gone. This is in contrast to that of the GLP-1 receptor agonist shown on the right, where the eGFR thresholds are in fact lower, but importantly, the glycemic efficacy is maintained even at that lower eGFR. Now, let's say you have a patient like ours where clearly she needs to be on either a GLP-1 or an Sglt2, and we need to know what to do with her other antihyperglycemic therapies. So to keep it simple, we just need to look at, is this patient also on insulin or a sulfonylurea? Because if she is not on insulin or sulfonylurea, then we don't have to worry about it. We can go ahead and add the GLP-1 or the Sglt2 with no fear of hypoglycemia. However, like in this case, if she is in fact on either insulin or an SU, then I would suggest that you look at the A1C. If the A1C is greater than 8%, you've got a cushion, and therefore adding in the GLP-1 or the Sglt2 is going to be okay. You will counsel the patient about what hypoglycemia feels like, what to do if it occurs, but generally speaking, you'll be okay. But if the A1C is less than 8%, as it is in this case, then we need to look at reducing or discontinuing the sulfonylurea to make room for this other agent. And in the case of insulin, perhaps reducing the insulin, But remember not to stop the insulin cold turkey. And of course, if unsure, please reach out to other members of the team in order to help make that decision. So in her particular case, she is on a sulfonylurea in the form of gliclazide, and her A1C is less than 8% at 6.8%. So therefore, for her, it does make sense to discontinue the gliclazide to make room for the vascular protective therapy. Now, the other thing to look at is her BMI of 24. Some may look at that BMI of 24 and say, okay, she does not need further weight loss, therefore I'm not going to use a GLP-1 or an SGLT2, and that would be a mistake in her. Remember that BMI thresholds are based on ethnicity, and as a Pakistani woman, that BMI of 24 is actually overweight. So there is room for her weight to go down, and therefore it is appropriate to still add the vascular protective therapy of either the GLP-1 or the SGLT2 inhibitor. Now, if you choose to go with an SGLT2 inhibitor, these are the practical things that you need to discuss with the patient. How the drug works, therefore stay hydrated, therefore genital hygiene, stopping in acute illness, and generally not using in type 1 diabetes. And as I like to joke, it'd be a nice t-shirt for patients to have when they get an SGLT2 inhibitor that says pee, rinse, and wipe. Now, what about for a GLP-1 receptor agonist? Now, that often is a shorter conversation because the main thing that we need to tell patients about is the potential for GI side effects. But I always remind people that 80% of patients are not going to have the GI side effects, and 20% of you might. And for those of you that do, it happens early and it tends to be transient. So it will in fact go away, and it's a matter of your body getting used to things, if you will. Some strategies that one could take to try to lower or lessen those GI side effects would be stopping to eat when you're full, which is frankly something we should all do, avoiding spicy foods, smaller meals, staying well hydrated, and if necessary, they can take an antiemetic. The other thing that can be useful, particularly if using semaglutide or liraglutide, is slower titration of the dosage. This would go beyond what is in the product monographs, but because these devices are clicky pens, one can count clicks and actually give doses in between the recommended ones in order to allow for an even slower titration of the GLP-1 receptor agonist. If it's the subcutaneous form that the patient chooses, then the pharmacist or the diabetes team can do the teaching. If it's the oral form, then there's no teaching required. We just need to remind patients how best to take the medication to ensure adequate absorption. And that's essentially taking it on an empty stomach, taking it with a little under half a cup of water, so a couple of sips of water, not too much because we don't want to drown the pill, and then waiting 30 minutes to allow the pill to fully absorb before putting anything else into the stomach. So back to our patient, type 2 diabetes, ASCVD, must be on a GLP-1 or an SGLT2. We would need to get rid of the gliclazide in order to make room for that based on the A1C, and then we would decide with her which agent she would go with. And the idea is that we have to have that conversation because this is the CAPTURE study data, 13 countries, 9,800 patients, global study, those living with type 2 diabetes, and you'll see that the overall use of GLP-1 or SGLT2 is still under 25%. But what's scary is that even in the group in the middle who have cardiovascular disease, it is under 25%. So clearly work left to be done by all of us in order to improve these numbers. So to summarize, there's an abundance of evidence and therefore guidelines have updated accordingly, but yet the implementation of those data continue to be a struggle that all of us need to work on. The 4 patient types are very clear. Simply remember that if they're on a sulfonylurea or insulin, then take a look at that A1C to decide if any adjustments are needed. And finally, it is everyone's job, whether you are a cardiologist, nephrologist, endocrinologist, primary care, all of us have that role to add outcome reducing therapy when necessary. Thank you.
Okay, thanks for that, Alice. You have a bright future ahead of you with your side gig in terms of making T-shirts and mugs and themes and memes. So don't give that up. So we're going to play the poser and the professor. So I'm the poser. Everyone knows you're the diabetes professor, big practice guidelines person. So here's my question. Do we make too much of this? Well, if they have heart failure, well, if they have atherosclerosis, the vast majority of people that we see in the office, I'll make up a number, 95% of people with type 2 diabetes are going to be at risk for heart failure, for atherosclerosis, for stroke, for myocardial infarction. Is it really worthwhile for us to go through this academic exercise? Should we not just say, wow, you should be on an SGLT2 inhibitor and a GLP-1 receptor agonist. We need to work out the economics and the affordability, but those two drugs are highly complementary. Most people should be on both. What would you say to that?
I would agree, to be honest with you. And I think this is the dilemma between what we might do in the clinic, what we might do for our parents, and then what we might have to think about if you're writing a guidelines document. So when you're writing a guidelines document or a guidance document to a country, for example, then the bar is a little bit different because you need to still consider a cost to society. People are going to then ask, well, show me the data. Show me the randomized control trial that shows that, yes, you should just start everybody on this. And at this point, we do not have those data. But then in the clinic, and certainly if this was my father, for example, then I'd be thinking, okay, well, I'm not going to get the randomized control trial data answering every single question that you can think of. And at some point, in my mind, it's sort of using common sense. So that's why I think in the clinic, the approach may in fact be different, but we need to recognize when writing a guidance document, the bar is different. And maybe there's a way to put those two together, but then that's when the critics come out and say, okay, well, how could you be so broad in terms of your recommendation?
Yeah, that's okay. When you get to the gates of heaven, St. Peter does not hold your guidelines activities against you. So don't worry about that. So I often annoy people, as you know, and when I speak to my pharmaceutical colleagues, one of the things I say that annoys them is generically, oh, these drugs are all the same in this class. You could take away, randomly 5 out of 6 drugs in that class. Just leave me one, and I'm still going to get the benefits. And I won't go through all the people I've offended. We don't have enough time. But how do you feel about the SGLT2 inhibitors and the GLP-1 receptor agonists? Of course, some are a little different and the trials are a little different. But do you really think that these drugs are more similar than different, or are there really molecule-specific considerations?
In the SGLT2 space, I would say far more similar than different. And I have often said to my primary care colleagues, for example, who have far more important things to be thinking about and remembering and a lot more than you and I do, that it's completely unrealistic to ask them to remember all 3 SGLT2s, the doses of all of them, and then sort of flip a coin each time, a 3-sided coin each time, and pick one. In my opinion, I would say to them, pick one. I don't really care which one. Pick one that you like, get comfortable with the dose. In my mind, it's really 10, 10, 100, 10 milligrams EMPA, 10 milligrams DAPA, 100 milligrams CANA, because the other doses don't necessarily offer any more cardiorenal protection. So just pick one, get comfortable with it, and use it. And you're not going to do your patient a disservice. On the GLP-1 space, and you know this very well, the data are a little bit different. So there you, again, same idea, pick one, but then which one you pick may have more to do with practicalities as well in terms of access, and then get comfortable with one and just use it. That would be my practical approach to that.
Okay, so Joe Biden is looking for a new head of the FDA. And I'm going to make you head of the FDA right now. And I'm going to say, we have a new coagonist coming in phase 3 that looks fantastic, tirzepatide. It's a GIP GLP-1 receptor agonist. We know what GLP-1 does in terms of cardiovascular outcomes. The FDA recently is starting to move back from this obligatory large cardiovascular trial obligation, but we've never stuck GIP into patients on top of GLP-1, let alone, and we have no idea what it's going to do. And the genetics from Mendelian randomization studies are a little bit confusing about GIP. So you're the head of the FDA today, not Janet Woodcock, not Josh Sharfstein, it's Alice Cheng. What are you going to say about our need to do, and they're doing it anyhow, but would you make everybody do a new cardiovascular outcome study for a new chemical entity, or would you use some other criteria? We're trying to reduce the cost and length and time for developing these drugs. How would you approach that?
So first of all, the FDA is hurting pretty badly if they've got me as the head of the FDA, but okay, so let's take that scenario.
It could be a big step up for the FDA, trust me.
And let's say they did in fact do that. In my opinion, I think when you've got a new entity in the mix, so as you suggested in the case of this coagonist, you've got a new entity in there. You've got the GIP piece in there. And Dr. Pfeffer's talk earlier was brilliant, right? Showing all the examples of how we assumed certain things would work, but then it turned out it in fact didn't. And when you've got a new kid on the block, I think it is in fact important to do that trial. But when you have yet another SGLT2 inhibitor or yet another GLP-1, and that mechanistically is very similar, then I think it is reasonable to say, are there other ways to collect those safety and perhaps superiority data, such as real-world evidence? And I know the FDA's sort of spoken a lot about that already and have further guidance as to how to do that, because these trials are very expensive and take a long time, and lots of patients are involved. And is that money best spent when it's another entity within a class that one is familiar with? That would be my thoughts on that.
Yeah, and so I think a good segue is to real-world evidence. We actually have a review in Endocrine Reviews coming out on real-world evidence, specifically dealing with diabetes, and I think we've been overwhelmed in the COVID-19 area. But how do you view real-world evidence versus RCTs? You started to address this. You know, RCTs can take 5 or 6 years, can be unbelievably expensive, with increasing, computerization and databases that we have now. One could do global real-world studies very quickly, much less expensive, with a higher power, and kind of randomize the folks by the virtue of their characteristics. So do you think this is the future, or is Mark Pfeffer going to rule with RCTs forever as the gold standard?
I still think RCTs are here to stay. And when you're doing a comparative analysis of drug A versus drug B, I think randomized controlled trials are necessary to show efficacy and to show that comparison. But there are many limitations. And the other piece I would bring up about RCTs is the kind of patients that are included tend to be very similar. And diversity and inclusion in randomized controlled trials is not the best. And they're not truly global, although many countries may be involved. But when you look at ethnicity makeups of many of these large trials, it's really not that representative. And that's where real-world evidence could be very helpful to answer some of those other important questions. But I'm going to throw it back at you then, Dan. What are your thoughts on that RCT versus RWE? Because that's a very real question now.
Yeah, so I think in this particular space, if there's no preclinical or genetic evidence for harm, then we should not demand an extra 5 or 6 years and an extra $300-400 million expenditure. We should use real-world evidence. In the case where there's some sort of suspicious, ambiguous preclinical signal, or the genetics suggest certain alleles might cause harm and we don't have a good explanation, that's different. So I think we're out of time for this session. I want to thank everyone for tuning in to Alice's lecture and allowing me to tag along, and we look forward to the next part of our program.
Thank you, Dan.
Ladies and gentlemen, I'm John Cunningham. I'm speaking to you from London. I'm a nephrologist here, and my co-chair for the final session of this meeting is Mark Pfeffer, who is well known to you, cardiologist in Boston. So good evening to you from both of us. It's actually good morning here. It's very, very late at night in London, but I won't bore you with that one. So we're finishing with a debate, so-called, between a cardiologist and a nephrologist. Now, the more observant amongst you will have noticed that these two individuals share the same name. They are, in fact, related to one another, and the first challenge you're going to have is telling them apart. And there's a fair degree of similarity, and we can certainly see that the lineage there is common to both. That said, though, I think it's an interesting topic that we've picked here, a cardiologist talking about the kidneys and the nephrologist talking about the heart. Now, if you asked this question 20 years ago, you said it's a waste of time. There's really no crosstalk here at all in terms of understanding here. This is very different now, and I think you'll appreciate when these two start talking that we're now in a world where both sides of that particular divide that used to exist are now heavily engaged with one another, and that has to be a good thing. So without further ado, we'll kick off at this point. We're going to start with Phil, the nephrologist, and he will introduce the proceedings. With you, Phil.
John, thank you very much indeed. Let me just get my slides up and running. So I think, do you see me? Mm-hmm. Great. Okay. So, John, thank you very much indeed. I'm Phil. I'm the nephrologist. So would you entrust your heart to a nephrologist? So here are my disclosures. Now, I know it's been a long evening for you in Canada. I'm going to tell a light-hearted introduction to the talk. And you probably are aware of our Premier League soccer. We have something called OptaStats, and we went out, and this tells us about things like how many kilometers each soccer player runs during a game, how many passes they make, etc., etc. So we did some OptaStats here in clinicians around the world ranking what are the most important organs or structures in the body, and this is what we came up with thousands of entries. Number 1, the left kidney. Number 2, the right kidney. Number 3, the heart. Number 4, the brain. And I'm aware that there's a large proportion of the audience who are diabetologists, and we wouldn't want to miss you out. So number 20 is the pancreas, sandwiched, you'll see, nicely between the bladder and the rectum. And if you remember when you were at medical school, certainly in the UK, our beer-drinking rugby players, well, they all turned out to be orthopedic surgeons, of course. So moving on to more serious matters. So what I'm hoping to convince you over the course of the next 10 minutes is that nephrologists do know a fair bit about the heart. We see many different aspects of cardiac disease in our practice, and that we've actually learned how to deal with this. I hope I can convince you. So first off, how common is cardiovascular disease in patients with CKD? You'll see this data on the left from the Kaiser Permanente population around the Bay Area of San Francisco, that as GFR declines, we get a stepwise increase in cardiovascular events and cardiovascular mortality, as you can see, down to GFRs of less than 15 or end-stage kidney failure. More so, when we look at dialysis patients on the right here, you can see that the annual mortality of dialysis patients over the age of 75 is something like 30%, a huge number. Even those aged 55 to 64, we have a 15% mortality, and this is cardiovascular mortality. Now, when I was a young registrar, we were always told that our patients died from accelerated coronary disease. Well, that's not coronary disease as we know it. Like on the left here, the classical atherosclerotic plaque with a bit of interval calcification in there, of course, but we're more used to seeing the medial calcification, the stiff arteries, and there's definitely a heterogeneous vascular disease going on in our CKD patients now. So much so that looking at US RDS, so US Renal Data Systems data, in terms of the causes of cardiovascular deaths in dialysis patients, only about 10% are associated with acute myocardial infarction, whereas more than 2/3 are said to be associated with arrhythmia, cardiac arrest. And when we go on to look at the factors that are contributing to the cardiovascular disease of our patients, yes, we have the traditional risk factors that we see in many other conditions, diabetes, smoking, anemia, etc. But we also have some novel risk factors, as you'll see in the light blue, they're not really boxes, but hyperphosphatemia, PTH, oxidative stress, inflammation, low vitamin D are all important contributors. And some of these are just novel to renal disease, but there are many, many factors that contribute. So let's go on to talk about structural heart disease. We know that if you follow a dialysis cohort, you'll see left ventricular hypertrophy, gross left ventricular hypertrophy in some patients. And we know that those with the greatest hypertrophy are the ones at greatest risk. So this is mortality, and you can see here that the worst 25% in this study who developed further hypertrophy over the 18 months between echoes had something like a 50% 4-year mortality. So what else do we know about this left ventricular hypertrophy? Well, we realize that even the nephrologists know that it's not great muscle. There's scar tissue fibrosis, disorganizing the myocardium with capillary rarefaction. And we know that there are contributors pushing towards this in the form of CKD, mineral and bone disease. More of that in a second, as well as traditional risk factors like hypertension, etc., etc. So let's go on to talk about Ckd Mpd vascular calcification very briefly. You can see it here. This is the pre-contrast scan of a patient about to have a coronary angiogram, a dialysis patient, and you can already see the ghostly outline of the coronary arteries. My brother tells me that's a mitral valve replacement, by the way. And now we go on to, look at the outcome of these patients with vascular calcification. So we know from studies of almost 20 years ago that the patients with the worst calcification score or the worst pulse wave velocity have got really, really poor outcomes. So if I just try to go back, so we're looking at something like an 80% 6-year mortality for patients with the grossest calcification. So it's really bad for these patients. For years, we've been wedded to the belief that high phosphate, progressively high phosphate, as you can see here, this U-shaped curve from observational data was associated with mortality. And sure it is, and but no trial has shown that actually reducing phosphate actually improves the outcome of the patients. But we also have learned in the last 10 or so years that FGF23, so fibroblast growth factor 23, a novel biomarker important in causing phosphaturia in normal health and as CKD progresses, is very important, certainly in animal models of LVH. And this wonderful study shows that at 7 days or 14 days after an intramyocardial injection of FGF23, there was gross hypertrophy compared to vehicle. And we are still looking at this as a potential target in our patients. So let's go on to talk about arrhythmia and sudden cardiac death. You see, we've only got 10 minutes and there's a lot of things to cover. So we've known for a long time that our 3 dialysis week program for dialysis leads to problems around the long weekend break. So in other words, Friday to Monday, Saturday to Tuesday. And data, again, from the US RDS has demonstrated that the risk of death, of hospitalization, of arrhythmia, of MI is all greatest after that long weekend break. So be around the time of the first dialysis session of the week. And there have been some studies, nephrological studies, using ILRs, implantable loop recorders, trying to investigate this a bit further. Admittedly, they're small. These aren't cardiological RCT size, are they? But what they've shown us is that whereas many would have thought previously that the main cause of arrhythmic death in a CKD population would be tachyarrhythmia. In fact, the preponderance from these small studies appears to be bradyarrhythmic asystolic death where it occurs. So anyway, what are we doing to improve things? You'll see that I'm not going to give up straight away and say not a lot, but unfortunately, we don't have a great deal of evidence in nephrology in terms of big RCTs. We know that RAS blockade's good for our patients' hearts. We know that blood pressure control is really important. We're looking at things like giving more dialysis. It seems to be very, very valuable in certain patients. And we know that we should be avoiding a positive calcium balance. But apart from that, we haven't got much in the way of RCT evidence to prove that treating some of these things I'm just pointing to here actually leads to major outcome benefit of our patients. So let's go on to talk about renovascular disease, something that I've spent many years investigating. So about 10 years ago, we had two large RCTs. Well, they are in nephrological terms, so around about 1,000 each. In fact, the Coral study, you might remember, was a bit more than that. But Astral study, which I was involved with in the UK, was around about 800 patients. And what these studies showed was that if you take unselected patients with renal artery stenosis, then there was no benefit in terms of outcomes of renal function, of all-cause mortality, of cardiovascular events from stenting compared to usual care. And yes, these were criticized, and our good friend Chris here stuck the boot in on both trials, as you can see. However, what definitely happened was that after Astral was published, you can see that the 30,000 stent procedures going on per year in Medicare in the US reduced to something like about 12,000 after that publication. So something happened, and it was this, there was a lot of cardiological oculo stent reactions. So seeing the stent and seeing the stenosis on the way through to the coronary arteries and sticking in a stent on the way. So we, at least by getting people to think about selecting patients, we were able to stop these drive-by cardiological stentings. So the last topic, just very briefly, is heart failure. And this is something that my brother actually specializes in. And, we know there's a lot of heart failure and CKD comorbidity, and there's no doubt that cardiologists and nephrologists should work together to offload the patients with severe cardiorenal syndrome. And here's an example coming towards the end of just exactly how to do that. So this specific case, again, it's renovascular. So a 65-year-old lady, 3 episodes of acute flash pulmonary edema over 12 months, gross hypertension, as you can see, 3 agents, a patient with gross atheroma, GFR dropped from 60 to 22 mils per minute in just 15 months. And you can see bilateral severe stenosis, in fact, 3 vessel stenosis, there were 2 on the right here, and quite good kidney size. So if ever there was going to be a case that would improve with revascularization, and those are the 3 stents you can see there going in, it would be this one. So this lady, we undertook single kidney GFR measurement. It's quite easy to do. All you need is a chromium labeled EDTA or iahexol plus a DMSA to give you split function. And you can see that this is the right kidney, look, pre and post stenting. This kidney was the 9 centimeter kidney, no improvement afterwards. However, the left one, bigger, 11 centimeters, went from 16 to 32 mils a minute, doubled. And most impressively, look, the blood pressure dropped superbly, only onto 2 agents. And look what happened to the cardiac MR parameters. So mass went down by 1/3 at just 4 months. Left ventricular diastolic volume halved at 4 months, and ejection fraction increased absolutely by 11%, or a quarter, basically. So a great result if you select your patients properly. And then really, finally, we now have the advent of the Sglt2 inhibitors that are not just anti-diabetic drugs. These, we believe, are cardiorenal medications, and the nephrologists as well as cardiologists are getting used to using these in their patients. So we have the DAPA CKD study, which included half of the 4,000 population was in fact non-diabetic CKD, and dapagliflozin showed just as good benefits to the renal outcomes as in the diabetic cohort. And similarly for heart failure in DAPA-HF, I'm sure Paul might mention that as well. And, you know, we do have, of course, the Credence study. So this is my last slide, actually. And so would you entrust your heart to a nephrologist? Well, I hope I've convinced you that we're experienced in dealing with, you know, a range of cardiovascular abnormalities in our patients, and we've got wise to this. Unfortunately, though our evidence base is increasing, the definitive trials are still lacking. You've heard that many, many times from nephrologists. But, you know, we do have the current aim surely is to, excuse me, treat all risk factors at a very, very early stage. That's what we must be aiming for. So the last two slides, excuse me, we do think a lot, of course, and hopefully we do have some action. And then team working is most important. And I started with a Premier League soccer discussion, and now to finish on a great one. So this is my favourite team, Leeds United, who obviously got promoted last year. So teamwork is crucial in cardiorenal disease. So thank you very much for listening.
So excellent, thank you very much. I'm Paul Cower, I'm a cardiologist, and it's would you entrust your kidneys to a cardiologist? And over the next 10 minutes or so, I hope to be able to persuade you that as cardiologists, we can help improve the prognosis and quality of life for huge numbers of patients with minimal impact on adverse renal function, and in many instances, actually helping to protect kidney function without needing to obsess about repeated measures of HbA1c. Now, when I was preparing this, I found an image that I thought was going to allow me to present my case in one single slide. And it came courtesy of Donald Trump with this quote: "You've worked so hard on the kidney, very special. The kidney has a very special place in the heart. It's an incredible thing." And I suddenly realized what I've been missing for many years as a cardiologist. Actually, the kidney was part of the heart. And of course, we were therefore, as cardiologists, already managing the kidney. I then realized that my source of information was not as reliable as I had first anticipated when I saw this quote that felt that the moon was part of Mars. And I realized I'd have to search for a bit more data. So these are my conflicts of interest. And I'm going to start with an anecdote of a lonely cardiology ward round. And this is a few years ago, and I'd done a several-hour ward round, and I had just finished, and I was walking through CCU towards my office. I was on my own because the junior doctors were all on a lifelong learning course, learning how to reflect on reflection. And one of the nurses called me over and said, "Paul, I'm really worried about a patient who's just been transferred from the medical assessment unit, and they look really, really unwell." And I flicked through the notes, and I was impressed that a diagnosis had been made, but it was a diagnosis called ACI, which I'd never heard of before, although it did mention heart failure and atrial fibrillation. And there was a surprising plan to stop nephrotoxins. And I was a little bit flummoxed, so I went in to see the patient. And I saw in front of me a patient that looked like they had decompensated heart failure with elevated venous pressure. They had pitting edema and lots of it, typical for a Portsmouth patient, also typical to have two right legs. And they were also connected to an infusion of Hartmann's as well as antibiotics. And as fast as the fluid was going into the arm, it seemed to be frothing out of their mouth. And I was able to stop the fluids, give them some intravenous furosemide, and they soon started to feel much better. And what I learned was that they'd been concerned about the patient's GFR. They'd given something called an ACI, or what I now know is an AKI alert had been triggered. And as such, the automatic response was to give fluid and antibiotics. And what we can see here is a baseline GFR of around 45 to 50, because we know that it often fluctuates in heart failure. And actually, when we remove the congestion, the GFR, you can see, stabilizes and starts to improve, although it doesn't quite return to normal, which is something I think we typically see when patients become very unwell. It affects all aspects of their bodily function don't quite return to normal. And we were able to recommence these drugs that would be called nephrotoxins, the RAS inhibitors. And what is a key message, I think, and I think cardiologists, and particularly those focusing on heart failure, are particularly good at, is ensuring that patients with heart failure are decongested. And we know that fluid retention is bad for the patients. They feel awful. And we also know that it's bad for the kidneys. So congestion is bad for the kidneys. It's one of the key determinants of deteriorating renal function in patients with heart failure. And this is a nice study from the US, and I just get you to look at the panel on the left. And these are patients discharged either without congestion or with remaining congestion at discharge, and they've either had no worsening renal function or worsening renal function during the hospital stay. Not unsurprisingly, the group that does worst in red here is a group of patients that go home with edema on board and they've had renal dysfunction, they've had worsening renal function. The group that do intermediately are those that go home with edema and haven't had worsening renal function. And almost overlapping Kaplan-Meier lines here, you can see, are the group of patients that go home decongested, and it doesn't seem to matter if they've had worsening renal function or not. And we can see this isn't unique to North America. These are data from ESC Heart Failure Association prospective registry, and we can see that actually going home congested is associated with much worse outcomes in terms of mortality and hospitalization. And these are drugs that have been labeled by many people now as nephrotoxins. Are of course not nephrotoxins. They are renoprotective, and they're drugs that have helped transform the prognosis for patients with heart failure and reduced ejection fraction. And it's fascinating when you look back to mid-1980s. So when Consensus study was published with enalapril versus placebo in severe heart failure, reduced ejection fraction. In placebo, the 6-month mortality was 44%. So almost 1 in 2 people died within 6 months. And with the treatments that we have available now and what we call comprehensive treatment, and this very nice estimation of the lifetime benefits of comprehensive therapy published last year in The Lancet. So this is with sacubitril valsartan, beta blocker, mineralocorticoid receptor antagonist, and Sglt2 inhibitor. And this is comparing it to conventional treatment, not placebo, RAS blockade with an ACE or an ARB and a beta blocker. And you can see, if you look at the figure on the left, this is the difference between these two strategies in estimated event-free survival. And event-free survival is free of cardiovascular death or first hospitalization for heart failure. At the age of 55, that's almost 8.5 years different. Even at the age of 80, it's 2.5 years different. These are really, really impressive treatments that we can deliver to patients. These are data from the National Heart Failure Audit that in England and Wales we submit data to from all hospitalized patients with a primary diagnosis of heart failure. We see that between 9 to 10% of people die in hospital, but if you are managed on a cardiology ward, the outcomes are much better, and that's independent of multiple comorbid factors. So it's not just about cherry-picking, cardiologists cherry-picking the least sick individuals. If you don't come to cardiology, then we see that specialist outreach input does also make a difference. And I think there are data to suggest that at least part of the reasons behind this are the fact that we're willing to and prepared to use these drugs, these life-prolonging drugs associated with improvements of quality of life in our patients. And it is common to see some deterioration in renal function after initiation of inhibitors of renin-angiotensin-aldosterone system. It doesn't mean to say they've caused kidney injury. It means they're typically impacting on renal hemodynamics. And I'd just like you to draw your attention to A up at the top left. These are data from the ROL study with spironolactone in severe heart failure. And again, this is versus placebo, and these two groups are also separated as to whether they had worsening renal function or no worsening renal function, as defined by a reduction in GFR more than 30% from baseline to 12 weeks. All-cause mortality, the group doing worst, placebo with worsening renal function, intermediate placebo without worsening renal function, and then almost overlying Kaplan-Meier curves here with spironolactone. And the benefits of spironolactone don't seem to be mitigated by the development of worsening renal function. So this can give us some assurances that we can continue these drugs in the vast majority of patients. And I think this has already been mentioned in by Phil, by Go and colleagues for the top one, and also with the cohort studies, that if you have chronic kidney disease, it's the vast minority of patients it's a minority of patients that end up with end-stage renal disease. The vast majority of patients die prematurely or have cardiovascular events, and we need to reduce those risks. So if I've hopefully presented the case for cardiologists, and I've just used heart failure as an example, if it isn't cardiologist, who else would you entrust your kidneys to? Well, during the time we've seen these massive improvements in the outlook for our patients with heart failure, here's some data about HbA1c and glucose lowering, where we've seen no difference in this meta-analysis in mortality. And in fact, when you look at individual studies, over-aggressive glucose lowering potentially detrimental. What about the nephrologists? Landmark trials in nephrology. You might be expecting a build to this slide, but actually this was it. But no, seriously, this is the build to the slide. The vast majority of studies in people with severe kidney disease or on dialysis, non-significant p-values. But we're better together, aren't we? As Phil said at the end, better together. And I pulled this slide out from a talk I gave 18 months ago, and suddenly realized I can't use it, of course, anymore. So let's keep it better together, kidneys and the heart, cuddling each other. We've worked hard in the UK, bringing together the Renal Association, the British Society for Heart Failure. We've had 3 cardiologists and 3 nephrologists representing those societies, and we've produced a consensus statement about a pragmatic guide to change in renal function associated with treatment in heart failure. Before that, we were giving different advice and a focus on, I think, renal function from the nephrologists. And as Teresa Mcdonough was saying earlier, the cardiologists being less concerned about that. But we've got a pragmatic, sensible approach. And, you know, one of the key things is if a patient has AKI and are unwell, then actually assess the patient, don't automatically give them fluids, and work out what the problem is. It is a high-risk individual. The fluid overloaded decongest them. If you do need to stop prognostically important drugs for heart failure with reduced ejection fraction, so RAS inhibitors, make sure that you have a system in place to reinitiate those and re-up-titrate them. That is really important. And we worked together cohesively in the UK to develop research. So Phil mentioned the loop recorder studies, and we worked together on one of those that he showed. And we've got a large outcome study called Ironman, which I'm the chief investigator for. And we've built upon the experience of nephrologists giving intravenous iron and learning from them for many, many years to design this study, which is a primary endpoint of cardiovascular mortality and hospitalization for worsening heart failure. There are a few studies going on with intravenous iron outcome studies. I think this is the best acronym, and we hope to be presenting this in a year from now. So in conclusion, treat the patient and not the test. Clinical assessment's key. Congestion's bad for patients, is bad for the kidneys, and specialist care by cardiologists and a broader heart failure multidisciplinary team does make a difference. RAS blockers aren't nephrotoxic. I think, as Phil said, Sglt2 inhibition is a major advance for treating patients with cardiorenal disease, and I think that's been embraced already by certainly by heart failure cardiologists and by nephrologists. And I think that'll bring us even closer together. And cohesive working will help improve outcomes for all of our patients. Perhaps provocatively to finish with, perhaps the next debate could be, who would you trust to manage your patient with type 2 diabetes with CVD or multiple risk factors? And I'd like to propose the cardiologist again.
Thank you. Thank you. John, may I say the thank you for both of us?
Please do.
Okay, well, quite a spectrum. And I think the emphasis in this ending the symposium, which is everybody's doing evidence-based, we get down to N=1. And I think the nephrology and the cardiology at its best is when we're N=1 and there's no trial to help you. You've got to do the best you can for this patient. But the one interface that I think is advanced heart failure, and I define advanced heart failure is a patient I can't give the medications I want to give to them. And often it's the kidney. And it's an amazing thing. You add the LVAD, the mechanical circulatory support, and suddenly kidney function looks well. So people with severe heart failure, bad renal function, and it is their heart. John, I think we have to do our thank yous. So you and I have talked about this. The person we want to thank is their mother for bringing them together, allowing us to have two experts, brothers, who tell us different sides of the coin, but both, and I heard this loud and clear, both taking care of N=1 using the best data they have. So thank you both, Phil, Paul, thank you.
Thank you.
I think we've got some questions, but I think we haven't got time to pursue those, unfortunately.
It's our first cardiology, diabetes, and nephrology at the Limits meeting, and Dan and I would like to take this opportunity of thanking all the speakers for their truly wonderful presentations, which have clearly made this meeting over the past 2 nights so interesting and so informative. Our thanks must also go to the chairpersons who have managed not only to navigate the complex logistics of a virtual meeting, but also chaired each session so well. We would also like to thank Carol Foslu from our conference organizing team, who has helped coordinate this meeting from the very beginning. And likewise, a very big thank you to the technical team, which are based at the Royal College of Physicians in London, led by David Jones, who have undertaken the complex logistics of this virtual meeting. They've done an amazing job. Of course, the support of the pharma industry should also be acknowledged with gratitude. And so I'd like to leave with the last word to my co-chair, Dan Drucker. Dan, it's been a pleasure working with you, and I hope we were able to return to Toronto to a face-to-face at the Limit meeting, hopefully next year. I'm going to hand over to you to say the final few words.
Thanks very much. It's really been a pleasure. We will definitely have this in-person meeting going forward. I just want to thank the audience. This has been an extraordinary year. We've all had tremendous pressures put upon us personally and professionally as healthcare providers. You're all making a huge difference. Let's all be kind to each other. There is light coming and a warm spring and summer, and thank you so much for helping us make this meeting a cool thing through your participation. We really appreciate it.